webinar, so happy to share that. We'll also go over some information about medication, and then we'll spend a lot of the time really how to approach the treatment of sleep difficulty. So what's gonna be some of the gold standard recommendations, and then we will end with some kind of practical first moves and answer any questions that might come up throughout today's presentation. So the sleep landscape. Chronic insomnia is very prevalent, as I mentioned. When people have difficulty falling asleep, staying asleep, or waking up too early, when this is frequent, a few days a week, when it has gone on for at least 3 months, that's when we kind of consider it to be chronic insomnia. And across the major guidelines, there is widespread agreement that cognitive behavioral therapy for insomnia is the first line treatment. So although most people reach for a sleeping pill or a supplement, CBTI really has been shown across studies, across guidelines to be the most effective with the most durable effects across time. So here we just kind of outline some key points of agreement, and the bottom line is that CBTI should be the leading one. Again, it's not always possible or practical for a person, but it should be the one that leads. Medication can be considered more as a short-term adjunctive treatment, but should not be the foundation across these guidelines. And Dr. Alward is going to talk more about that. So let me talk a little bit about what CBTI is. So a lot of times when I ask people, what do you know about CBTI? And they know it's the gold standard. And I say, okay, what do you know about what it is? And they're like, I'm not sure. So I just like to go over a little bit about what it is and how it's delivered. So it is a short-term evidence-based treatment. There are no medications directly involved. So it's 4 to 8 sessions. It can be more or less depending on someone's response to treatment. But there's 5 core components. So this is across these components, we deliver them in different places in the treatment. However, they're all part of it. So the most important two are the first two, the sleep restriction and stimulus control. Sleep restriction is actually trying to, we don't want to restrict their sleep, but we want to limit the time in bed to match their actual sleep so that we can build their sleep drive, consolidate their sleep, and help them to fall asleep faster and stay asleep. We often pair that very early in treatment with stimulus control. That is basically using the bed only for sleep and sex. So a lot of times people with insomnia, they've spent a lot of time in bed. They're trying to catch up on sleep. They're trying to compensate. They're sleeping in on the weekends, or they're trying to sleep. They're tossing and turning, and it's just weakening the association between bed and sleep. So we are really trying to repair bed with sleep to strengthen that association. And then the other 3 pieces, the cognitive therapy, sleep hygiene, and relaxation, we include at different points throughout, depending on how a person, it might be used to best help them fall asleep. So the results show in our clinical practice as well as in studies that the time in bed restriction or the sleep restriction is going to drive most of the results that we see across different studies. So they've done a lot of not a lot, but they've done a few dismantling studies, really trying to figure out what are the active components of CBTI. And we often find it that sleep restriction component driving a lot of the results, with things like sleep hygiene having a very minimal effect on sleep improvement. So sleep quality at Muna Health, where we deliver CBTI, we see significant improvement in clinical scores. So we see about a 50% reduction in people who complete CBTI. So that's about 6 to 8 sessions. But interestingly, we also see over a 50% reduction in depression and anxiety as well. So this is the gold standard treatment for insomnia. We don't directly target depression or anxiety, but as sleep improves, we also see improvements in depression and anxiety. So it can be used when people have comorbid mental health concerns as well. And so now I'm going to turn it over to Dr. Alward. He has referred some patients to Muna Health, and we've kind of worked together, and we're really excited to be talking about how to partner with primary care approach and CBTI. So go ahead, Dr. Alward.
Thank you, Noelle. Thanks for the introduction and this opportunity to give kind of my primary care bent on managing insomnia in this type of primary care setting, and then how do you manage that along with medications. So let's go. So as Noah was saying, CBTI is really recommended in all the standard guidelines. And I'll just mention the American Academy of Sleep Medicine as sort of the primary option for folks with chronic insomnia. So that's insomnia that is greater than 3 months with no urgent or situational trigger. It's been going on long term, or there's been even escalating hypnotic use. There may be comorbid mood disorders, and certainly in older folks, we try to avoid sedative hypnotic medications. Medication has more of a standard or immediate role when there is more acute or situational insomnia. So again, less than 3 months. Maybe there's a life change or major traumatic event that occurred, and medications may have a role there. If you have a patient who wants to talk about their insomnia, wants to treat their insomnia, but wants to do that really quickly, they want a medication early on, and that along with CBTI can be helpful. If they just don't have access to CBTI, but they still need some sort of improvement quickly, or there's some uh, dangerous reason they need to get better sleep, so they work with heavy equipment or other things like that, where they need sleep more acutely. I think medications have a role. Residual symptoms, so sometimes if CBTI isn't totally effective on their own, there may be a role there. And always the lowest effective dose, and a plan for tapering or getting off of these medications in the long run. I think when you start medications, that is really a key, that patients know this isn't necessarily the sleep solution for the rest of their life. This is something that you can start with, but ideally, you will taper off of this as you do another treatment plan. So if you look at the American Academy of Sleep Medicine sort of ranking of how you should consider treatments for chronic insomnia, it really does start with CBTI. Second tier would be CBTI plus a medication short term. And really, medication by itself is really the last tier treatment option. So how can you combine medication and CBTI safely? I think that you should try to start CBTI as the foundation. That's what's going to give you the long-term gains, even if medication can give you short-term improvement. In insomnia, most studies will show you that the long-term improvement is not going to be there with medications alone. So medication is a short-term bridge, lowest dose, and just for the initial stages. Plan the taper early on, like I was saying before. If the patients have an understanding early on that this is not going to be the long-term treatment, it's easier to get them to taper the medications in the long run. So the evidence would support that long-term outcomes when the medication is then stopped and CBTI is ongoing will give you the best results. Some words that work there: we'll use medication briefly while you build the skills to become what keeps you sleeping, and then we'll taper it together.
And I love that you include this, Dr. Alward, because we get a lot of questions about when should they start their taper and how to best do it. And I think as long as the patient has a plan, when they're working with their CBTI therapist, it can be implemented at various points, but sometimes they like to have tangible skills, tangible things that they can go to, or they like to see some improvement in their sleep before they start tapering, even though they then potentially have increased symptoms again, and we'll help them through it. But it doesn't have to start at a certain point. It can be whatever's right for the patient. So love to see that there's some general strategies to do this.
And not all tapers will be exactly the same, but really letting people know up front at the beginning that that's the goal we have, and getting buy into that goal early on is important. Um, yeah, and I'm sure lots of you have seen this. I see it all the time, where patients have been on their sleeping medications. Here we've got, ideally it should be less than 4 weeks. I've got patients who have been on sleeping medicines for more than 4 years when you see them, and at that point it is a lot harder to get people to get off of those medications and consider other therapies. These medications aren't without harm, particularly in the older population. The sedative hypnotic medications can lead to higher rates of um, memory issues, falls, fractures, all of those things. And if you look at the Beers criteria, all of these sort of Z drugs and benzodiazepines are really recommended to be avoided in the senior population. Um, why medication often falls short, why it can be effective very short term, but tends to not be effective long term is sort of this cycle here that's described where, hey, this works, for whatever reason, I decided to start a sleep medicine. I started it, it's working, that's great. I'm going to start using it more regularly. Get to a point where I'm using it regularly now. It just doesn't seem to be quite as effective. So maybe I'll go up on the dose a little bit. I don't like that I'm going up on the dose. Let me stop it. I stop it and I just have a bad night's sleep. So now I've got this mindset that I can't sleep without it, that I need a medicine to go to sleep. And that starts to build on itself over time. And meanwhile, the reason they couldn't fall asleep in the beginning, whether it's some sort of, anxiety about sleep or hyperarousal that's developed, persists, and none of the medications are really going to address that. So that's when the relapse happens, and people feel like they can't get off of medications.
Yeah, what we sometimes see is that sometimes the accidental taper where they forget their pill on
Mhm.
vacation or they didn't refill it, and then it kind of has them test some of their beliefs about sleep, and they say, "Oh, actually, it wasn't helping me," or maybe I can sleep without it, and then we start to see a little more flexibility. But it's hard when it's been a long time. People feel really, really passionate about their medication and their routines taking it, even when it's not working any longer.
So class by class, most people are probably familiar with these. The benzodiazepines, zolpidem or Ambien, zopiclone, or Lunesta, Zaloplan, temazepam. Um, all of these can be effective short term, but have high risk for tolerance and dependence over time, and really should be avoided in the senior population. DORAs, the dual orexin receptor antagonists, are kind of a newer group. Suvorexant, lemborexant, or daridorexant. You probably know Belsomra, Dayvigo, and Quviviq. Um, they can improve sleep onset and maintenance and maintain sleep architecture. There's residual or minimal residual effects in the mornings, and you do have to be careful of some somnolence and abnormal dreams. And these are contraindicated in patients who have a narcolepsy diagnosis. Other ones that people use, doxepin or Melteon can have some modest benefit in studies. American Academy of Sleep Medicine doesn't recommend trazodone or diphenhydramine. I mean, those are definitely still used. And melatonin is used a lot, but not recommended for chronic insomnia.
So, thank you so much. That was so helpful. Now we're going to talk a little bit about how to combine these treatments in different clinical scenarios, including some, I think, a lot of questions about how to taper or how to approach a taper in practice. Um,
Right. So this is a very common, scenario where people are coming to their primary care provider for help with insomnia. They may have been started on a medication years ago. They may have been taking a lot of over-the-counter medications, um, and you're going to consult them on how to improve their current strategy, which usually isn't working. That's why they're coming to you, and you're trying to get them into the idea of CBT-I as the primary driver of improvement over time. Um, so in that case, you're going to introduce CBT-I. You're going to talk about that, and then talk about sort of tapering the medication if they're open to that. And I always sort of encourage people or reduce their anxiety a little bit about that by saying that, you're going to go gradual. You're going to do it while you're doing the CBTI so that, you're getting follow-up and you're learning tools to manage your sleep, even if you're going down on the medications. typically go pretty slow. I think most people recommend about a 25% taper every week or two. And for some people, that may even need to go slower, especially at the very last part of their taper, which seems to be the hardest for a lot of people, particularly for benzodiazepines. That taper sometimes isn't weeks, it can be months, and the last milligram can be the hardest one to get off of. So, some patience there and some reassurance that this is pretty normal as they're tapering is important. Um, Let them know that there's going to be rebound, and the rebound is usually in that first few days to a week or two, but it will get better. Some of the withdrawal symptoms, particularly from the Z drugs and the benzodiazepines, can last longer though, and that can look like worsening insomnia because there'll be sleep issues, there can be irritability, anxiety, um, even when the rebound period is sort of done with. Um, it is good to have a schedule, especially if you're doing a kind of a systematic taper. You don't have people kind of bouncing in and out of their medication use. I think having that fixed taper and making sure the patient understands it is important. If they're on a bunch of different sleeping aids, both prescription and over the counter, one or the other for their sleep, I would try to simplify that before you start the taper if the harder to get off of medications. And then make sure you've got good follow-up. So even if they're doing their CBTI and meeting with their therapist there every week or two, I would still make sure that you're checking in as well to show that you're supporting them on the medication management.
Yeah, and it can be really helpful to keep a sleep diary. One of the things that we ask people to complete is what the medication what medications they took on a certain night so that we have evidence that it works or it's not working, and then it helps us to identify patterns. So if they take something occasionally but their sleep's not better, we can help them to challenge some of the thoughts that they might have related to that medication.
All right, so a few other pretty common scenarios here. Um, just new insomniac. Maybe this is due to some sort of uh, life event, traumatic event. I think in that step, sleep education, things that you would normally tell folks, can be sleep hygiene, it can be a few other things, and even a short-term hypnotic if needed. But again, with the understanding, and I think this is where counseling sometimes falls short, that letting people know right away that this is not, a medication that we're expecting you're going to need long term to manage your insomnia. That as you process this event, we're expecting the sleep to improve. It still is important to address insomnia like this, I think, because these types of life events, if not, if the insomnia doesn't improve acutely, can turn into chronic insomnia over time. So making sure that you acknowledge what they're going through, help them through it, even if it's not chronic insomnia, hopefully you can prevent that from developing over time. Um, Next would be chronic insomnia. They haven't taken any medications. I think that's a great opportunity to introduce them to the idea of CBTI and try to get them referred into that, or even trying some digital options. I don't know, Noelle, if you have any digital options that you go to for folks or not.
Well, I
The one
usually
I,
recommend that the CBTI coach app
yeah,
that is
yeah,
along with usually is supposed to be delivered along with actual CBTI. We do know that the digital products are usually not as effective as telehealth or in-person CBTI just because the accountability piece is so huge. It's sort of a difficult treatment. So I don't usually recommend like a digital only, but in-person or telehealth.
yeah. Um, Chronic insomnia, depression with anxiety. Um, yeah, concurrently treating those can improve both of them. So don't wait. I think that's something that, it's a thought that has changed for me, and I think how we manage this over time. I think it used to be, well, was it the chicken or the egg? Are they not sleeping because they're anxious or depressed? Maybe if we treat that, the insomnia will get better. I think now we're like, there's no reason to, you know, try one and see if the other gets better. You can treat both of them simultaneously and see that both of them improve. Um, if they're already on long-term hypnotics and they're like, I want to get off of these, I'm worried about, my long-term memory, I'm worried about other risk factors, um, then I think that's a great patient to say, I'm glad you come to this conclusion. I agree. Sleep medicine specialists agree. Let's try and get you off these medicines. We'll do it in a structured way, but also introduce them to CBTI as the way to get more lasting long-term benefits and improve sleep. And then if you've got older folks who who are also having trouble sleeping, I think introducing them to CBTI and then really sort of introducing them to the idea that these medications, as you age, are less safe. You're more likely to have accidents, falls, fractures, memory issues, delirium. It's really not recommended that you continue these. That hopefully you can make some headway there. There are some folks who've been on their Xanax for 30 years, and it's going to be a tough discussion, but sometimes you can get them at least to lower the dose a bit. And if they have the CBTI along with that, I tell folks it's an investment. You sleep every night of your life, and if you can make this, 6 to 8 session investment and sleep a little bit better and get off of some of these medications that could be harmful for you, it's going to be a win.
Yeah, and I think that there are definitely some people who are reluctant when they hear therapy. It's sort of therapy light because we're really sleep focused. It's just as if you're going to your primary care doctor and talking about sleep. You're not going into your deepest, darkest secrets or your history, your childhood history, anything like that. We're really focused on specific behavioral and cognitive strategies that can help them to sleep better. And most people do see improvements within the first few weeks. So although it's not as maybe quick as medication might be, it does have, again, the more long-lasting effects.
I tell people too, I get a lot of patients who'll say, well, I've already done that. And I think what they mean usually is I've already done like sleep hygiene. I've done what my doctor told me. I don't drink caffeine at night. I have, shaded curtains on my windows. I have a noise machine. I'm doing all the things that you're talking about. And like, well, it is a little bit more than that. There's more involved and you're not alone in not having a lot of success with just those things. Sometimes you need to add some other components.
Exactly. And I think last month we covered a couple quick strategies that providers could give someone in an office. It just if they have a few minutes to have a consistent rise time, to use the bed only for sleep. Those two paired together will really help them. It will also plant really strong seeds when they start CBTI and they hear it from their doctors, then they hear it from their therapist. So it does. It goes a long way when they've heard the message multiple times. When they heard from their doctor, they're 85 years old and they need 8 hours of sleep, which is not necessarily true. It's a lot harder then to make improvements. So thanks for going over all of that, Dr. Alward. Let me pause now. We only have a couple of minutes, but I would love to answer any questions that people might have. Let's see. There is a question about insurance. So at Muna Health, we are in network with most commercial insurance plans as well as Medicare in California, New York, New Jersey, Florida, Texas, and Massachusetts. Other providers for CBTI can be found through Psychology Today or other online resources. But at Muna Health, we are in network with most commercial insurance plans.
What about hyperarousal for ADHD patients?
How to address that?
Yeah, they have a lot of sleep issues. Yeah, and just wondering how to approach that through CBTI or medication or clonidine or
Are you talking about adults or pediatrics or
both,
both?
actually. Yeah, both,
Okay.
either or.
And I mean, the medication, that's a tricky one where the medications are oftentimes going to be stimulants. So, making sure that they're taking them at the appropriate times and everything. Um, for folks who have anxiety and sleep issues, I don't know if you've ever used guanfacine as an option to treat their ADD symptoms. Sometimes they'll do that instead of increasing a dose of of stimulant medications. Sometimes that's helpful. And then I think CBTI is still an option. So if there's anxiety and other things, and sometimes, you know, the CBTI and the lessons that they can learn there, I think can be really helpful in sort of structuring, their sleep and their wake times and so forth. I don't know, Noelle, if you have more to add there.
Yeah, we have a lot of people that have comorbid insomnia and ADHD, and they have a very difficult time falling asleep most times. Usually they get into doing something and then it's 2 or 3 o'clock in the morning. So we can definitely work with them. We usually have like longer wind down periods, developing strategies to help them kind of fall into sleep a little bit faster. The other thing to keep an eye out for is a delayed circadian rhythm. We see a lot of comorbid ADHD, insomnia slash delayed circadian rhythm, but it's masked as insomnia because they're reporting difficulty falling asleep, but when they can sleep any time that they want, they're not having those difficulties. So it's just because of their forced schedule. So be careful, just be sure to assess for the circadian rhythm. We do that with at Muna Health, but it can be something that might be missed if they're coming in complaining that they can't fall asleep. But we can help them. Just might have different strategies to help them depending on what their difficulties are.
Okay, thank you. Yeah, I use guanfacine a lot, and yeah, that's been very helpful. You wouldn't say that would be a contraindication then as a sleep aid, or that because I would be using it for something different like ADHD and
Yeah, it's not labeled for sleep, but I do feel like it helps with the ADHD without adding as much a stimulant of burden, to the patients. And then if you have patients with ADHD or other developmental, like autism type disorders, particularly in the pediatric population, that is one area where melatonin is recommended.
okay, yeah, I do that a lot. Yeah, so the guanfacine is very helpful. And even for the delayed circadian rhythm, can we correct that through CBTI?
We do that with melatonin dosing. It's going to be earlier in the night with a smaller dose, or morning light to kind of shift that circadian rhythm. And I think maybe Dr. Alward, do you have anything to add about the melatonin dosing?
It can no, it can be a little bit complicated. You have to get the timing right, and so it's oftentimes not like, oh, I'm just going to take my melatonin, like 5 milligrams of melatonin at bedtime. It's really more trying to take it earlier and just pull your circadian rhythm a little bit forward, so you're ready to fall asleep a little bit sooner.
Oh,
But
okay.
I feel like it's also just a real struggle. I mean, they have to be so consistent with this. And even if they are able to shift their circadian rhythm forward an hour or two, if they stay up late on a weekend or whatever, it kind of blows the whole situation, and they've got to redo that. So it's really a tricky one to maintain that kind of improvement long term. But yeah, we'd recommend the timed melatonin, the bright light in the morning, trying to keep things darker in the evenings at home, um, and then just a lot of consistency. Once they've got in there, they just have to lock into that schedule and be really
Okay.
consistent with it.
Okay. Thank you.
Yeah. And we have had success in CBTI with those folks as well. Again, the morning light and the consistency are going to be key. I know we're at the end of time, so I just want to quickly go over. Thank you for your questions. If there are more questions, we're happy to take those via email. But our next one will be discussing insomnia in older adults. It's a very tricky population just because of the oftentimes the complexities. So we will be announcing a date and time later, but would love to see people there. If you have questions about Muna Health, and if you think that your patient needs a full course of one-on-one CBTI, we do have individual therapists. Like I said, we are in network with most commercial insurance plans, and we'd be happy to do an assessment with your patient to determine if they would be eligible. So thank you so much for your time today. Again, appreciate Dr. Elward for joining me, and if we can answer any questions, we would be happy to do that. So thank you, everyone. Have a great day.
Thanks, everybody. Thanks, Noel.
Thank
Bye.
you.